Yeah, okay, great. So today I'm going to talk you through a bit of medicine that's kind of developing at the moment to do with the subconscious and the boundary between the physical and the mental. So I hope you'll find it interesting, and I'm just trying to get the word out there for this kind of new and interesting field. So it's called functional neurology. So I'm going to go through what that is, give you some examples of diseases which I'm sure you will have heard of but not realize that they are actually functional. Talk about the history, and then go through how they develop, how they're diagnosed, how they can be treated, and what the future kind of holds for this area of medicine. So basically, there've been a number of names for these diseases over the years, from psychosomatic to hysteria, conversion disorders, medically unexplained symptoms, psychogenic diseases. And it's basically how they can be summarized are symptoms, physical symptoms truly felt by a patient, or you can see even, but there's no organic cause identified. So we usually think of these in a Freudian sense of it's a somatization. So a patient has undergone psychological trauma, largely childhood traumas. They haven't wanted to experience the psychological pain of that trauma, so they convert it into a physical symptom, which is then expressed in various ways. So examples of the diseases are irritable bowel syndrome, things called non-epileptic attacks, where you get uncontrollable shaking that looks like epilepsy, but in reality, it's somebody's mind kind of dissociating from reality. You get fibromyalgia, also known as ME, chronic fatigue syndrome. And I mean, I personally have the theory that a lot of these new diseases that we're seeing, especially in America, chronic Lyme disease, lots of mold and spore allergies, are in fact a functional disease and a conversion of psychological trauma into a physical symptom. So they usually come under pain. They affect the function of movement, so you can get limb deformities, or it's to do with energy and exhaustion, basically. And importantly, they're different from factitious diseases where the patient makes it up, because we can actually measure directly the brain and show different patterns of function when it's a disease that the patient has made up for purely attention, malingering, or Munchausen syndrome, compared to a functional disease where the brain is actually it's rewired itself, and we can prove that these symptoms are real and not created. So a bit of the history. They were first described by Briquet in 1859, and then Freud famously described the different patterns of psychological trauma being expressed, so conversion, dissociation, those kind of things. And usually a functional disease is known as a conversion disorder. However, over the kind of 20th century, there've been a lot of controversial studies where these diseases haven't been kind of rigorously tested, and the literature around them has become kind of marred by controversy. But then in the past kind of 20, 30 years, the consensus has changed. We're starting to see more rigorous studies around them. And yeah, so the future is bright, actually. So now functional diseases make up to 50% of primary care presentations, and in a typical neurology clinic in a hospital, around a third of new admissions are actually functional disease. So it's a very large problem. So if I go through kind of the pathophysiology and how these diseases are thought to actually develop, typically childhood trauma, can be sexual trauma, and then you get specific functional disease depending on what kind of trauma you have experienced. We see this a lot in refugee populations who've undergone very traumatic lives, basically. And when it's not dealt with a psychologist, psychiatrist, if you don't have friends or family to talk about these things with, this is when they're often converted into physical symptoms. So I'm just going to go through this is called the integrative model of functional disease. This is a brilliant paper. If anyone fancies reading it, give me an email and I can send it over, discussing kind of constructivist philosophy, and how we view reality based on our implicit biases, and then how these things kind of contribute to what we experience phenomenologically in reality. So to start with, so this PNES, which the kind of end of this thing, this is a psychogenic non-epileptic seizure, which is just one form of a functional disease. Like I said before, it looks kind of to the layman as a epileptic fit, but patients kind of shake uncontrollably, often get misdiagnosed as having epilepsy, but the disease isn't epilepsy. It's not misfiring of electronic signals in the brain. It's purely a dissociation from reality, and it's often thought that when a trigger, such as reminding of this past trauma, the patient goes into this state of reduced consciousness, shaking uncontrollably. And so, yeah, the reason why they choose this set of, well, say choose, but why they go into this set of symptoms, i.e. the shaking uncontrollably, is based on these factors at the bottom. So if you have a family member with epilepsy, if you know somebody with epilepsy, your subconscious is thought to see that as a valid form of sickness behavior. So that is why you would kind of do this role over converting into something like irritable bowel syndrome or fibromyalgia or chronic pain syndrome. So yeah, the form that your trauma is expressed in physical symptoms is based on kind of cultural factors, and there are a lot of culture-based diseases. Off the top of my head, there's one called DAT in kind of the Indian subcontinent. There are specific ones for China, Korea, Japan. These are also known as folk diseases. And yeah, the way the trauma expresses itself physically is very culture dependent. So here in the UK, this is quite a big one. Psychogenic non-epileptic seizures. Okay, so when this is all triggered, there are a number of things contributing to it. So your threat perception, internal, external cues, and so this example of an optical illusion is basically an example of the way that what we see is based not only on reality, our mind and past experiences, expectations all contribute to what we actually perceive. And so in a similar way, it's thought that your brain kind of makes these heuristics, shortcuts, when every time it sees something, and yeah, these all contribute to the progression to something like a functional disease. If these shortcuts are kind of miswired, and your perceptions aren't reflective of true reality. So all of this seizure scaffold is evidence-based. So we've shown that these patients have kind of elevated arousal all the time. Their cortisol levels are increased, their heart rate, it's not that it's higher, but it has lower variability. So there's no difference between a shocked state and a non-shocked state. They are constantly, have increased arousal, which again contributes to the brain always being kind of ready to go into one of these uncontrollable shaking attacks. And then finally, the last bit is a decrease in inhibitory processes. So normally you can tell yourself to calm down, you can relax a little bit, but we've shown that within these patient groups, they go through thought processes of repetitive negative thinking, catastrophizing about past things, and this again creates a chronic stress, which would decrease any kind of cognitive ability you have to tell yourself to calm down. So this progresses to the seizure itself, and then following the seizure, the patient is obviously in a reduced state. They've just expelled a load of energy. They feel a kind of sick role behavior. People come around them, give them attention, and none of this is conscious, but it feeds back into the subconscious of a positive feedback loop of this. I have just done this. I'm now in a reduced state. I'm now no longer thinking about the traumatic experience that I'm trying to avert from. So the positive feedback, and then that through synaptic plasticity reinforces this whole scaffold again, because the brain is a plastic organ, and it changes depending on positive feedback, basically. So how are these diseases diagnosed? So the patients have usually been round to every specialty, rheumatology, neurology, psychiatry, and then finally they'll come to a medically unexplained symptoms clinic, and a specialist, usually neurologist or psychiatrist, will show kind of, they'll have had all the physical tests to show there's no organic disease. And, you know, a doctor can go through the history of a patient, usually see a clear traumatic experience in their life, which has led to the onset of the symptoms. But often there's no clear cause. I mean, Freud would argue that there's always a cause, and things like hypnotism can be used to get deeper into the subconscious and just like dredge up the things which may contribute to it. But then clinical, there are a number of clinical signs which can definitively prove that the disease is present. So Hoover's sign here at the top is a classic one for functional weakness, where the patient may say, I can't lift my left leg. You ask them to lift it and there's no power in it. But then when you ask them to lift their right leg, they will push down with their left in order to lift their right. And by such a simple clinical sign as this, you can show that there is actual power in that left leg, but their conscious mind is unable to control it. So when they're not thinking about it, and that's a key point to functional disease, it's not conscious at all. So distraction techniques and trying to get into a rhythm, meditation can help, and things to distract the conscious mind are kind of the routes to getting better, basically. There are a number of specific tests, such as video EEG. EEG is the test where you have all the electrodes on your head, and this concurrent with videotaping the patient in a seizure. If you record the electrical activity, you can distinguish whether it's an epileptic seizure versus a functional seizure, for example. And then, there are a number of different clinical signs. The good thing about these diseases is they are treatable. The patient has usually, as I said, gone round all the departments of a hospital, and is kind of none the wiser as to what's wrong with them, thinks they're crazy, thinks there's nothing that can be done. The most important part of treatment is to explain that these are treatable diseases. The patient is not crazy. They are not under conscious control, and a good explanation is the best way. So a typical way to explain to a patient how these diseases develop is to say something like, not all of our bodily functions are under conscious control. When you ride a bike, when you walk upstairs, you don't think, I need to move this leg to 90 degrees, put it down. So in the same way, your mind has got into patterns of behaving which are not helpful. And the kind of aim of treatment is to get out of these patterns in order to get to a more baseline physiology, basically. So cognitive behavioral therapy is a key treatment that's about it's a talking therapy about trying to get out of these thinking patterns. It looks at giving coping strategies and kind of ways of thinking which get you out of the rut of repetitive negative thinking, catastrophization. And if you see yourself going down this thought process, which is only going to lead into one of these, if you recognize that you're about to go into a non-epileptic attack, for example, then you can enact strategies to avert that, basically. And then the third step in treatment is a consultant level care. So these are psychodynamic treatments, looking at the trauma with a psychotherapist, trying to deal with that, and then also physiotherapy if it's a functional movement disorder. Again, as I was saying, trying to focus not on the movement itself, but on a rhythm to the movement. So distracting the conscious mind, that often makes the symptoms a lot better, which kind of has deep implications for, I mean, consciousness, free will, whatever you want to term it. But the body basically always wants to be on. It wants to be tense. It wants to have high reflexes, and it's actually your brain which relaxes your body. It sends signals to coordinate, but it does that not by actually activating. It does that by relaxing in certain ways. And so when these processes are disrupted in functional disease, the signals misfire, you get tenseness, and yeah, things like the uncontrollable shaking. So what's the future of functional disease? In the past 10 years, well, past 5 years, we've had the inauguration of the Functional Neurological Society in the UK and America. That's a growing society, and these diseases are kind of being recognized more generally and globally. This graph shows the typical kind of treatment of these diseases. You're not expected to get better straight away. It's more of a sinusoidal and hopefully progression to the symptoms getting better. And then the final picture, which I was hoping to get a kind of discussion going around, if anybody is more into this kind of thing than me. The future of medicine is going to be affected by technology a lot more than it is already. So AI is currently being used by actually a professor that I've worked with to analyze patient conversation. So just by having a conversation with a patient and using algorithms to detect specific words and specific types of emotions within that, we are able to kind of see themes and predict strategies to help these patients. So yeah, as I said, I think this is a growing specialty. It's definitely going to be recognized a lot more in the next 10 years with the growth of lots of strange diseases which seem very new, such as chronic Lyme disease, spore forming or mold diseases, especially in America. Lots of these are actually recognized to fall under this category of functional disease, where it's not about an actual organic pathology. There's never been any kind of proof to there being a physical cause for fibromyalgia, chronic fatigue. All these things are a conversion of psychological trauma into physical symptoms. And yeah, I think over the next 10 years, this hopefully will come to light. So if anybody has any thoughts or questions, please let me know. Here's my email if anyone would like to get in contact with me. And yeah, I open the floor if anybody has anything to say.
Hey, Andy, thanks a lot for that. That was extremely informative. One of the best sessions in the last 24 hours. How much progress are we making beyond diagnostics? More on sort of treatment that is beyond just the patient being next to the doctor?
So treatment is extremely difficult in these patients. There's no kind of drug they can take to get them better.
Exactly.
It is, yeah, so antidepressants, antipsychotics have shown to have no difference, basically.
Exactly.
There's usually an element of depression and anxiety within these patient groups, kind of concurrently, which contributes to the symptoms, but curing the depression won't cure the symptoms. So it is more about the psychological treatments at the moment, which, you know, under current views of medicine, we don't value as much, but the kind of, I mean, yeah, psychological treatments are very varied, obviously depending on the psychiatrist, the patient, and their interaction with each other. If they don't like each other, obviously it's not going to work. So I kind of hope that, again, technology can come in here. There's lots of there's a few studies that I've seen about AI acting as a psychiatrist, and you might say that this, like, it's the human interaction that people want, but studies have actually shown that they prefer speaking to something they know is a computer than a psychiatrist themselves.
That's actually our work, some of that with Sophia the robot. Does neurofeedback work for this? Some of the things that we do, I sent a link. There's a company that I'm an advisor to, and what they do is you can do it remotely. And so they have a person in a chair with EEG, with the display, and they have them do some tasks. Some of the things that we do is with video game technologies, I can create an experience. And then by seeing how the conscious decisions you make and how your brain responds to that, I can start doing some diagnosis, or at least look at pathways, triggering pathways that induce this positive feedback loop that creates this. And so, and the interesting thing for them is they have the company, Minerva, they've been looking at psychological disorders. Okay. And what they've been doing is they actually use big data. And so they have like thousands of brain patterns of other people with different disorders. And then they measure people and then correlate across that, and then come up with neurofeedback processes to help kind of entrain the brain back to.
Hey, Gina, could you put down your contact details? I would love to get in touch. That's really interesting.
Yeah, well, there's a link to that company, and then I'm just a +852 638. That's my WhatsApp.
And Andrew, are you familiar with there's a I don't remember the French doctor's his name. He did a series of studies on the link between childhood trauma and multiple sclerosis. So he has but most of his research is in French, so I'm not sure it's available in English. And he has come up with the link between people that who have multiple sclerosis and how a lot of them are linked with childhood trauma. And the reason why I know about it is because one of my friend, actually, he has multiple sclerosis, and he has a very rare form of multiple sclerosis, and he did a lot of research on that area, and he actually managed to mitigate his symptoms, so he no longer have any episodes. And also there's another group of people that they play with they what they do is they call visceral manipulation. So it's a little bit similar to craniosacral, that they actually do a lot of body work, but they do very subtle body work on your body. And I have experience with it that if you have extreme stress, that your stomach actually rise up and cramp up onto your body, and there's a way for them to actually manually release that.
Interesting. Yeah, the boundary between neurology, well, the physical brain and the mind, is a fascinating topic. And I think, yeah, functional disease is basically the boundary between these two things. It's how your friend with multiple sclerosis sounds to me like, I mean, obviously multiple sclerosis is a measurable disease. You can scan and see the parts of the brain that are affected, but that is the reason that they are affected. You basically get fat loss around your neurons, but that's an inflammatory process, and chronic stress is an inflammatory process. These things they might seem physical, but in reality, trauma and the chronic stress that I was describing contributes to all these things in a physical way. What you said about the big data being the future, I think I completely agree with. Medicine needs to utilize big data, and yeah, so I hope one day in the UK we have the NHS, National Health Service.
Sorry, Andrew, we're out of time, but one more person I wanted to get. If you come across Ivy Wheat, she's been hopping in these different sessions, but her sister, they have a baby child who has these seizures, and they're about to lop off half of her brain. And I'm sure she'd like to talk to you because their whole family's freaked out about this. Her name is Ivy Wheat.
Yeah, if you would like to give her my email, or give me her email, I'm sure that would be fine.
Okay.
Andrew, I also know that you're out of time. Hi, Gino, it's May. How are you? I just wondered if you're familiar with the work of Dr. John Samo. He wrote a book in the 80s, I think, called Healing Back Pain, the Mind-Body Connection. He was a neurologist, I believe. And he was basically talking about the escalation of a lot of back problems. That's exactly what you pinpointed in terms of functional neurology. But he basically was a proponent that once they were able to identify that it's something in the mind or it's caused by extreme stress, that the mind can't fool itself. Basically, the back pain then goes away, even though they had diagnosis, of all sorts of that took physical manifestation.
Yeah, the funny thing is with functional disease, I think it's something like a third of symptoms disappear after the first consultation, where it's properly explained to them what their disease is, which is very interesting. And basically what I'm trying to do is just raise the profile of these diseases so people can, you know, get the help they need.
So the other 2/3 presumably are not understanding it or are not
No,
denying it? Or?
the other 2/3 would then go into either physiotherapy, psychotherapy, and I'm not sure on the figures of total resolution of symptoms, but the figures are very good after, especially when it's a movement disorder. I think 60%, 2/3, sorry, see improvement after, well, even after 18 months after a 6-week course of physiotherapy. So yeah, these diseases are not curable because, as I showed with the graph, the symptoms go up and down, and you get relapses, but the general trend is positive in the majority.
Well, thank you. This was a superb talk. I have to agree. This is one of the best I've heard in these 18 hours or so. Thank you.